guys who don't know, Professor Ben Bikman is up at, and correct me if I'm wrong, at BYU, and you study human metabolism and are just in my view, just a great. So really, it's a pleasure always having Ben on because he's such a good. It's a good way of explaining things. I have a couple personal questions. Well, Ben, let me just give you like 2 minutes to introduce yourself for people that may not know who you are, and then I'm going to be greedy and ask my questions up front.
It's your prerogative, right?
Yeah, and then I'll open it up to everybody else here. So go ahead and Ben, if you don't mind introducing yourself a little bit.
Yeah. So Shawn, like Shawn mentioned, I'm a professor at BYU, which means I have ready access to wonderful skiing all the time. So pardon my ski lines here. I'm the director of 2 labs, the diabetes research lab, which is a greater lab where there are a few different professors a part of that, and then the metabolism research lab. My focus historically and currently is insulin. I focus on insulin and particularly the pathogenic side of insulin, which is something I believe is not talked about often enough, although it's being talked about more and more, to my delight. But because of my focus on insulin, I've become familiar with ketones, because I believe that if you really want to understand ketones, you've got to understand insulin. And then all of that is looked at through the lens often of the mitochondria. What are the mitochondria doing in these different situations? And indeed, I just had my master's student defend his thesis yesterday, and a lot of the discussion was looking at ketones, mitochondrial coupling, and a protein called nuclear respiratory factor, which alters mitochondrial function in cells, including fat cells. Anyway, that's what's often on my mind. My wife and children are always on my mind, and the research is a close second.
All right, Ben, I'm going to just because the way we have framed diabetes and what actually diabetes is I think up for debate these days. I mean, obviously the traditional view has been through the lens of glucose, purely, we just kind of have these arbitrary cutoffs on saying this is what diabetes is, it's glucose. And now we hear more about insulin, but we also hear a little bit, mostly from the plant-based people, talking about fat infiltration into the cells. And then we also hear about mitochondrial health being maybe the real true pathophysiology of diabetes. Can you touch a little bit on all of those real quick and kind of give us some perspective on those things?
Yeah, Shawn, you'll have to keep me on topic here, but let's start with the glucose paradigm when it comes to type 2 diabetes. Yeah, that is the prevailing paradigm with type 2 diabetes, is that it is a disease of glucose. And I'm often quick to say that's forgivable historically, because historically the glucose was the main driver of diabetes, or the main symptom, the main manifestation, the polyuria specifically. And that we would see with type 1 most certainly, but we would see it with type 2 as well, as glucose levels were approaching and staying at those low 200s milligram per deciliter. That would overwhelm the kidney's ability to reabsorb the glucose and drive the polyuria. And historically, it was just so much easier to measure glucose because it's easy to measure a nutrient. However, as time progresses, it's becoming less forgivable, because we know that insulin, especially in the context of type 2 diabetes, insulin changes will precede the glucose changes by up to decades earlier. And so not only can we detect the problem better if we look at insulin rather than glucose, but we also treat it significantly better, because we know from some very well-controlled long-term studies that the more aggressively we try to push the glucose levels down in a type 2 diabetic with insulin, the more rapidly they die. So the risk of cardiovascular mortality goes up 3 times. The risk of cancer mortality goes up twice, so doubled. We kill the patients, and we make them sicker and fatter with the insulin therapy in a type 2 diabetic. And yet we do this in the midst of getting really great glucose numbers. So something's wrong. If glucose was the main driver of this disease, then getting the glucose to normal with insulin therapy in type 2 diabetics should be solving the problem, but indeed it's making it worse. So that is one of the single greatest professional goals I have, is to promote the awareness of insulin as a pathogenic molecule in the context of, well, many diseases, but certainly type 2 diabetes, and not just continue to look at glucose. If we just look at glucose, we look at it too late, and we treat it poorly. Now, Shawn, I totally forgot what your second point was. That was too long of an answer.
No, that's fine. I know there's a lot. So I wanted to address the issue of, the main driver of insulin resistance and diabetic pathophysiology.
Okay.
Fat in the cells, i.e. saturated fat. And
Yeah.
on the podcast, and then also mitochondrial.
Okay.
Goodness.
Yeah. So with regards to the origins of insulin resistance, it is multifaceted, and some might kind of roll their eyes to hear that and think, "Oh, that's a cop out." But please know, everyone, that is not a cop out. I've been studying nothing but insulin resistance for the past 15 years, and I can confidently say there are several factors that go into it. Including stress. Like we could in fact acutely start infusing the main stress hormones, cortisol and epinephrine at normal, at physiological levels that you see with stress, and we could make someone insulin resistant within hours of infusing those stress hormones. And cortisol and epinephrine are the main ones. So stress matters, sleep matters, although that's actually probably through those same hormones. Mild sleep deprivation, just one night, can cause insulin resistance the next day. And it's corrected quickly, thank heavens. Inflammation. We know people that have active autoimmune disorders will have demonstrable insulin resistance while the disease is more active. And then as the autoimmune disease subsides, so too does the insulin resistance, like rheumatoid arthritis. We also detect that in infections, in acute infections, as someone has more inflammation in their bodies. And then insulin itself drives insulin resistance. I understand that there is debate. Some prominent, even sort of low-carb voices are trying to promote the idea that insulin does not drive insulin resistance, but that is not right. There are absolute, undeniable evidence, publications, that hyperinsulinemia drives insulin resistance in the fat cell and at the muscle cell. We know that for certain, whether it's happening at the brain cells and liver cells and others, that we don't know yet. But we know it happens at the muscle and the fat. There are multiple publications that prove that point. Now, Shawn, to touch on the lipid, or the cell becomes clogged with fat, which is what many on the low fat side of the coin want to say. Interestingly, every distinct cause of insulin resistance that I just mentioned, the say cortisol, inflammation, hyperinsulinemia, all of those at least partly cause the insulin resistance by resulting in the accumulation of a fat called ceramides. Now, ceramides itself, I am saying that word plural on purpose because there's a whole family of ceramides. But all of them will drive ceramide accumulation. Now, the cell needs ceramides. It's there for a reason. But of course, as so often happens in disease, there's just too much of it. And ceramides are directly antagonistic to the insulin pathway. So when insulin binds its receptor and it starts initiating a series of biochemical events, ceramide stops that process from happening. So it is directly antagonistic to the insulin signal. Now, the truth is, ceramides are made from palmitate, the most common circulating saturated fat. So there is a hint of truth when people say don't eat saturated fat because that will cause insulin resistance. I'd like to think, I'm giving them the benefit of the doubt, and I think, okay, you're saying that because of the evidence that palmitate a saturated fat causes is the backbone for the ceramide, the initial ceramide molecule. But there's a disconnect. And I had to go through this learning process myself. Eating saturated fat is not the same as having saturated fat available in the plasma, for example, to be pulled in by a cell and turn that pathway on. Indeed, Volek and Finney have published some really great papers finding that you can be eating 3 times more saturated fat in the context of a low-carb diet, and the actual amount of saturated fats in the blood as free fatty acids or as bound on lipoproteins, as triglycerides, goes down. So there's a disconnect there when people want to confuse the idea that saturated fat at the cell is a necessary substrate for ceramide accumulation. We cannot confuse that with, well, then don't eat saturated fat. No, those two processes are not connected. And unfortunately, we overinterpret data. If you infuse saturated fat into a human or infuse saturated fat into an animal, or you treat cells like muscle cells directly with a saturated fat, you get a demonstrable, powerful inhibition of insulin, or an insulin resistance, more than with unsaturated fats. But that is not the same as eating them. And even still, if that's not enough, there is no animal source of fat that is purely saturated fat. Animal sources, in some instances, as everyone here knows, I'm sure, there can be almost a one-to-one of unsaturated to saturated. Not generally, it's going to be more saturated, and I would argue that's perfectly fine. Clearly, evolutionarily, these are foods that we cut our teeth on, but we cannot confuse eating saturated fat with high levels of blood saturated fat. There's direct evidence to show that that is not the case.
You know, I think you had mentioned that insulin actually drives saturated fat in the blood, if I'm not.
Oh, yeah. Yeah, and I didn't say that, but you certainly know that. Yeah, insulin drives palmitate formation directly at the liver from whatever carbons are available, and often that's going to be glucose.
Do you know, is there any papers on that, Ben, that you know of that demonstrate that?
Oh, the lipogenesis at the liver?
Yeah.
Oh, yeah. Oh, yeah, several. Yeah, and even fructose does that. In fact, Luke Tappey, a fructose scientist, I think he's based out of Switzerland, he once mentioned this, I've never forgotten, in a paper. Fructose is the most lipogenic molecule. And of course, if you're focusing more on animal products, you're getting no fructose. You may be getting a little bit of glucose from the muscle, and that's negligible and of course perfectly fine. But if someone's wanting to avoid fructose, say to lower their uric acid and try to control their gout, because that's a main driver of gout, fructose metabolism literally is causing uric acid production. And the more you shift towards an animal-based diet, or just natural, I'll say animal foods, you get ever less and less fructose. But yeah, Shawn, the idea that insulin drives hepatic lipogenesis, it's extremely well established.
Let me, and then the one last other component was just a little bit about the mitochondria and its role in diabetes, because I know you probably
Right. Yeah, there is, that's appropriate to mention. And the idea is twofold. As the mitochondria may not be working optimally, it is that you're getting incomplete combustion of fatty acids, and these incomplete fatty acid molecules exacerbate insulin resistance. And second, just the production of reactive oxygen species. So the drive, or that shift in the redox state within the cell and the greater oxidative stress, compromises some distinct parts of the insulin signaling pathway, altering insulin sensitivity in the process. Yes, so you have to have ideal or the ideal metabolic scenario, or mitochondria that are using oxygen well for the production of ATP, or for the production of heat through like a futile cycle at the mitochondria, or and you don't want it to be producing as much reactive oxygen species. Now, you need reactive oxygen species. Once again, this is a molecule that is absolutely essential to health, and there are studies in humans to show that when humans are dosing with excessively high levels of antioxidants, like vitamin E, they die more, mortality goes up. So you can't, this is not something we want to try to shoot down. We need oxidative stress, and it serves a purpose. But the idea is that if the mitochondria are supplied with more energy than they know what to do with, they end up producing more oxidative stress. And there's some decent evidence to support that. So there's this oversupply that isn't matched by the mitochondria's need to produce ATP. Now, I would add that some of that might be resolved if you could force the mitochondria to be more uncoupled. So when mitochondria are coupled, they will only break down as much energy as the cell needs the work done within the cell. In other words, the creation of ATP. So ATP production will drive the catabolism of nutrient. In the case of an uncoupled or mitochondria that are uncoupled, you've teased those events apart, that now the mitochondria are catabolizing nutrients like glucose and fat, not because the cell needs a certain amount of work done, but it's just breaking them down to waste the energy as heat. And that's the sort of futile cycle, which is so abhorrent to normal cells, because it just is a waste of energy. But in our environment, the modern food environment of hyper calorie, well, it ends up, that inefficiency, that mitochondrial inefficiency ends up being a pretty smart adaptation, or a way for the body to expend this excess energy and help fight obesity.
That's an interesting thought on that. Hey, so I'm going to get to some of these questions now, Ben. Thank you for that, and I thank you guys for indulging me my questions. But so this is from Patricia Jones, and she said she's heard that fasting will ruin your metabolism. Do you have any thoughts on this?
I sure do. Yeah, so starvation can ruin metabolism, and that was well published. There's a guy named Kevin Hall, and I don't agree with him in many ways, but his one study, it was quite compelling, where he looked at the people who'd gone through the Biggest Loser game show, and he looked at the difference, the shifts in metabolism or metabolic rate. And that's what I'm going to assume when someone says, fasting will wreck your metabolism. The scientist in me says, well, what do you mean by metabolism? Because that means, that can mean a lot of different things. But let's just say metabolic rate. Normally, metabolic rate is yoked to someone's body mass. Shawn, you're a bigger man than me. You absolutely have a higher metabolic rate than me. And mine is higher than someone who's smaller than me. But even if I were to gain 20 pounds of pure fat, my metabolic rate would go up. And if I lose 20 pounds of fat, my metabolic rate would go down. So body weight and metabolic rate are pretty yoked. In the case of these Biggest Loser people, we all know the game show, they go through incredible caloric deprivation, and I would argue starvation. Well, let me not say that. They just go through incredible caloric deprivation, and they lose a lot of weight, and their metabolic rate comes down like it's supposed to. However, as they gain the weight back, and they all do, metabolic rate should go back up in a sort of 1-to-1, but it doesn't. It stays lower than it should be. And so that, I would say, that is someone who's sort of wrecked their metabolism when they've gone through this incredible weight loss through severe caloric restriction. Now, I might have muddied the waters a little bit, but fasting is a state where you have fat to burn, and you don't cut muscle. That is the critical distinction between fasting and starvation. If the person is in a situation where they are cutting muscle in order to create blood glucose, then they are starving. If they are able to produce ketones from their fat, that spares the muscle. So people will say ketones are muscle sparing, and that is true in the context of a low carb or a fasted state. And by that I mean the fact that the person has body fat to create ketones, it diminishes the brain's need for glucose because, of course, the ketones end up being about 75% of the brain's energy in that instance. But if a person doesn't have enough fat, or if they have high insulin levels and they can't make ketones, then the body will cut muscle and use those muscle amino acids as substrate for gluconeogenesis at the liver. And now so that the cutting the muscle, now you are starving, and that is absolutely going to have a negative impact on metabolic rate, simply because by mass, muscle ends up being such a prominent part of metabolic rate, and of course such a main consumer of glucose. It consumes 80% of glucose after a meal, and that matters. If you start to lose that muscle mass, you've lost that massive glucose sink, and now the person starts to push towards hyperglycemia. And indeed, when the muscle falls, so to speak, that's one of the main events that mediates the transition from insulin resistance to outright type 2 diabetes. And at the risk, sorry, and I don't mean to change the topic, but if in insulin resistance, the person's hyperinsulinemic but normal glycemic, as they progress towards type 2 diabetes, the insulin stays high, and now the glucose starts to climb, and now they're hyperinsulinemic and hyperglycemic. And usually it's the failure of the muscle to adequately pull in glucose, and that could be due to muscle insulin resistance and muscle loss. Now they start to transition towards hyperglycemia and then get the diagnosis of type 2 diabetes. So, but to get back to the question, fasting will not wreck someone's metabolism. And I would add simply a caveat that if it's done well, and fasting done well to me means they aren't using fasting as a sort of high-browed version of a binge and a purge cycle. And I know people who do it that way, and that's not going to work. So that, they say, well, I only eat one meal a day, and that's my form of intermittent fasting. Yeah, but that one meal is a pile of shite, and it's all kinds of junk food, and they're just making up for whatever indulgences they were pushing off for the previous 23 hours. So if someone can be consuming electrolytes, staying hydrated, unless they do a dry fast, and there's a lot of, I believe there's some benefit to a dry fast on occasion, but stay hydrated, consume electrolytes, and then however you end your fast, do not end it with a meal that is spiking your insulin. For several reasons, and one of them being a potential for hypokalemia, as insulin drives the potassium into the cell and out of the blood. That can be deadly, although the person would have to probably do a multi-day fast to get that effect. But that's something called refeeding syndrome. But again, that's pretty rare. But nevertheless, don't end your fast on a meal that spikes your insulin. Because if you do, the person has had this prolonged state of fat burning, as insulin dictates which fuel is used. Is the body burning sugar, or is the body burning fat? Insulin decides that. So the person's been burning fat wonderfully for hours, and now they immediately stop burning fat and shift to this incredible load of glucose burning for an acute period of time. I believe that is not healthy. Now, if you have a kind of low carb athlete like Zach, like I think of Zach, Shawn, and we both know that he's very deliberate in kind of spiking or dosing in his glucose. Well, there's a way to use that well, and to do that well, I believe, and I think he's a good example of that. But for the person who's not Zach Bitter, or even remotely that active, let's say there's very little upside in having this massive rush of glucose and insulin every 23 hours.
All right, here's another thing that's kind of a little bit what you started to talk about. They're talking about protein, and there's a couple questions here. I'm just going to combine them. So one person is asking, can we discount protein calories when trying to get leaner and counting calories in general? In other words, is it a free macronutrient? There's somebody asking about at what threshold level will protein significantly raise insulin levels? And there's another question that's talking about, what about on a carnivore diet is fat-free because we're eating meat and protein? So what are your thoughts on protein as a macronutrient in general?
Yeah. I do not think protein should be considered a calorie source. I think that's not accurate in how protein ought to be accounted for. Not only does it have a high metabolic expense just to digest, but it is not going to be used as a fuel unless the person is just eating fantastic amounts of it. And by that, I mean, like I don't think you could eat enough meat to get there. Maybe you could, I'm sure you could, but this is generally a person who's just drinking whey shakes or all those crappy little junky protein boxes that everyone buys at Costco. Those little protein carton drinks. Yeah, but the liver has the ability to turn protein into glucose, and then the body just has to clear that nitrogen, which it can do. The kidneys can do that quite well, of course. But I think protein should not be counted as a fuel. That doesn't mean it's not a macronutrient, but it shouldn't be looked at as a fuel. It should be considered a building block, and the person ought to make sure they get enough of it. And Stu Phillips, of course, is a champion of this, but his research has shown the older we get, the more we need, and that's on the order of about 1.5 grams per kilogram body mass. If the person's obese, then we say ideal body mass, where they think they need to get. Protein does affect insulin, and I hope that I've not ever caused confusion there. These amino acids are, in some instances, not all of them, some of them are insulinogenic, but that can vary from a very mild insulin response to a substantial insulin response, depending on the need of the body for glucose. If the person is hyperglycemic or eating the protein with glucose, the amino acids from that protein will amplify the insulin spike from the carbohydrate. If the person's consuming these amino acids in the absence of a carbohydrate load or in normal glycemia, then there's an incredibly modest insulin spike. And importantly, as I've talked about in the past, that is typically matched with a comparable glucagon response in that low glucose state. And glucagon is important because it's the yang to insulin's yin. And when insulin's promoting anabolic and synthesis and accumulation, glucagon is promoting catabolism and breakdown of molecule. And each are absolutely necessary. We need them both, but in the context of just overall metabolism or obesity and insulin resistance and type 2 diabetes, appreciating that the glucagon is going to go up with the insulin, it puts that little insulin spike in context. In contrast, the insulin spike in the hyperglycemic state or combined with consumption of glucose, there is an inhibition of glucagon. So glucagon's going down and the insulin's going up, so that insulin to glucagon ratio gets extraordinarily big, an order of magnitude larger, as opposed to staying comparable, where someone has normal glycemia and is not eating the protein with a glucose load. I hope that all makes sense. That was a bit of a rant. It might have been a little confusing.
Yeah. So I mean, I think it was made sense to me. And here's another question. It's kind of a couple parts here. It's one, thoughts on depression and grief and relationships to insulin resistance, and then that on higher fat diets.
Yeah.
How do we do high fat diets and with insulin resistance in order to lose weight?
Yeah. So the idea it's interesting. There are known antidepressant and anti-anxiety medications that I'm sort of answering the question, I guess, in a bit of a weird way, and maybe I shouldn't have started with this, but I'm going to go with it now. There are antidepressives that cause insulin resistance, interestingly enough. And I don't know the mechanism of that, but it is an unfortunate side effect. Almost every neurological disorder, from Alzheimer's to Parkinson's to migraine headaches, bipolar disorders, depression, is often shown in research to be correlated with insulin resistance. Now, I am using that word very deliberately. It's correlated, so I can't speak to a mechanism. Interestingly, all of these same disorders, neurological disorders, have also been shown to be instances of brain glucose hypometabolism. So we know that in these scenarios, in these pathologies, the brain is not consuming a normal amount of glucose. And that could be a consequence of a central nervous insulin resistance, because there are insulin-dependent glucose transporters in distinct regions of the brain. And if those regions have become insulin resistant, it could perhaps be manifest as this brain glucose hypometabolism. So in other words, some of these pathologies could be a consequence of the brain simply starving, or going hungry. Maybe I shouldn't use the dramatic word starving. And then we ask the question, well, what can we feed the brain if it's going hungry because it can't get all its energy from glucose? Well, there's only one other fuel, and that's ketones. So that could be part of the power, and indeed some of the evidence showing improvements including in depression and bipolar disorders and migraines and Alzheimer's, and ALS, where a ketones or a ketogenic diet improves these outcomes. And I have to mention the migraine one because just because it's so interesting, unappreciated, and it's so old. I think the earliest study I found looking at the use of a ketogenic diet in migraine treatment is from 1929. And then there was a follow-up in, I think, like 1931, just a few years later. But it's shocking. I got a colleague in my department one time, he was telling me, this was about a year ago, how he would get debilitating migraines 1 to 2 days a week, and sometimes he wouldn't be able to teach his class because it would just be so bad. But this was happening for years. He'd get 1 to 2 a week. And I mentioned to him this research, and I think I sent him these older papers. And then I see him all the time, but we didn't talk about it again. And then several months later, so this was just a few months ago, he stopped by my office. Ben, I don't think I ever told you, I started doing a ketogenic diet after we spoke. And I've gone from 1 to 2 a week to, in the last 6 months, I've had 2. And, I mean, that's just life-changing for this guy. What used to be so debilitating and almost predictably debilitating now is extremely uncommon. And the 2 times he had it, it was because he was indulging. And theoretically, I guess the ketones got low, and the brain started to get a little hungry, and he would experience that as some kind of pain, apparently. But yeah, these multiple neurological disorders, including depression, could be a result of alterations in brain metabolism, and improving insulin sensitivity and perhaps even providing ketones to the brain from time to time may help combat those disorders.
What are your thoughts on diet to overcome insulin resistance? I know you talk about fat, carbohydrates. How does someone dial that in? Do you think there's a best way for that in general?
Yeah, yeah, I do. I do think there's a better way, a best way. But to be fair, I will say there are probably a number of ways, and that if someone, almost regardless of what they do, if they go from a standard American diet, the insulin sensitivity will get better. And I would say, as terrible as it is to say to this audience, yes, and believe me, I take no pleasure in saying it, even a vegan diet is going to help someone improve their insulin sensitivity. Now, they're going to cause other problems, and I believe that is unsustainable for human life. I believe that very, very strongly, and make every effort to make sure my students know that as undergraduates, and them, I'm very sensitive to them being swayed by this new religion of veganism. And I want my students to know, we just got done covering blood pathologies in my pathophysiology lecture, and I made a point of emphasizing that a vegan will die from iron deficiency anemia or pernicious anemia, 2 different types and 2 totally distinct types, unless they are supplementing. And that to me suggests that something's wrong. But I would hope that every rational vegan would admit, yes, there are nutritional deficiencies, and I happen to be privileged enough to know what they are and wealthy enough to afford the supplements. So just acknowledge the privilege, and don't try to push that on other people that don't have those privileges, economically speaking. And then we'll get along just fine for the most part. But yes, even a vegan diet where I find the common ground from vegan to carnivore and every omnivore in between is if someone is reducing the consumption of processed foods, they're going to take an enormous step in the right direction, because they're going to be avoiding those most insulin spiking of the carbohydrates, the processed starches and sugars, and they're going to be avoiding incredible amounts of seed oils, which alter fat cell function, driving fat cell insulin resistance. And that's typically where the insulin resistance begins, at the fat cell. So the avoidance of the processed carbohydrates and the processed fats, or seed oils particularly, then I believe there's a lot of common ground. If I'm talking to a vegan and we can agree that that is a foundation of a healthy diet, then we're going to have a reasonably pleasant conversation, as long as they don't start to claim that they're saving the planet.
So here's a question about, and I don't know if you are able to answer this, maybe you are. It's about any thoughts on preventing uric acid and kidney stones on either ketogenic or carnivore diets?
Yeah. So there are, so uric acid accumulation is a driver of gout, of course, and humans and other primates have generally across all animals and mammals are unique in that we don't break down uric acid very quickly. Other animals have a uricase, this enzyme that will break down the uric acid and help the body just get rid of it nicely and neatly. Fructose is the main driver of uric acid production, but meat can contribute to this. However, just because of the DNA from the meat, the purines from the DNA is also implicated in causing uric acid. And I'm saying that just to be fair. However, I know of no evidence where someone is getting gout from eating meat alone. And I do think that's necessary. And I'm not just saying that because of the audience here. I don't know of a situation where a person is getting gout and they're eating a meat-based diet. I think a lot of that evidence where they find correlations between meat consumption and gout, and there's strong correlations. There are so many confounding variables in these kinds of studies. And frankly, fructose consumption could be a big one. But we know that the actual metabolism, the breakdown of fructose, causes the production of uric acid. And that's not only going to drive gout, but also certain types of kidney stones. Now, you did mention kidney stones, and kidney stones are also, as much as we understand them, exacerbated by changes in urinary pH. And I cannot remember the specific direction here, but as the urine becomes too alkaline or too acidic, it is increasing the risk of uric acid stone production, or calcium or oxalate stone production. And we know that the kidney stone will have a unique composition, and urinary pH does play a part there. Insulin alters urinary hydrogen excretion. Now, I'm a little embarrassed to say I cannot remember which direction it pushes that, but it does push the urine into one of the more, it does alter urinary pH, increasing the risk of stone formation. That I know for certain. I just can't remember which direction. So when it comes
it's acidic. If it becomes more acidic, it does drive stone formation. Yeah.
Yeah. Well, and I know you also get a different type of stone if it's too alkaline. I just can't remember which direction insulin pushes the pH. But whether the urine has become too alkaline or too acidic, in both instances, you can get stones, or unique stones that will form in each instance. But yeah, I would say the evidence implicating meat is not fair. That if you tease out the fructose consumption or beer consumption, because all that yeast, all the DNA from the yeast, which is extraordinarily high, not only do you have the yeast, but you also have a sweetener in there to make it more palatable. It's anyway, like as they look at the ancient, the early English kings, and they want to point the finger at all that meat heavy diet. Yeah, but they were drinking a profound amount of beer. And I looked at a statistic, interestingly, from medieval times, and the amount of sugar they put in their alcohol was like 10 times higher than the traditional amount of sugar, or now the current amount of sugar. But I'm the perfectly wrong guy to be talking about alcohol, because I'm a good Mormon boy. I've never had a single drop of it in my life, so I don't really know too much about it.
All right. Someone is asking, you kind of touched on this with some of the mental health disorders, but specifically dementia and insulin resistance. Any thoughts or?
Yeah. So dementia, the most common being Alzheimer's disease, but dementia is an umbrella term to kind of encapture any type of cognitive decline, including with Parkinson's and others. But Alzheimer's disease is so connected to insulin resistance that people refer to it as type 3 diabetes. I don't love that term because that makes someone think it's something else entirely, but it really is just the insulin resistance has become so bad, it's affecting the brain. So I'd say it's insulin resistance of the brain rather than saying it's type 3 diabetes. But the evidence there is so compelling. There was a study from Finland a number of years ago where they looked at this huge long list of lifestyle variables in people that got Alzheimer's or didn't. And age was, of course, massively significant to that. Now, this is just correlation. Education level was uniquely significant, which it helps me be some optimistic, but I think that basically means, does the person continue to challenge their mind? And then that likely helps push off the dementia. And then ApoE4 genotype, so having the ApoE4 gene also was significantly related to Alzheimer's, but then nothing else was. Smoking status, alcohol consumption, sex, it didn't matter. The only other statistically significant variables, all 5 of them that measured insulin sensitivity or glucose tolerance, and there were 5 distinct measurements there, like fasting insulin, fasting glucose, 2-hour post glucose challenge glucose and insulin, and then one area, I don't know, area under the curve insulin or something like that. But every metric they used to measure glucose and insulin was statistically significant in this study. And that, to me, it was nothing else. Age, so it was age, ApoE4, and education level, and then all the markers of insulin and glucose handling. So in fact, full disclosure, one of the reasons I personally follow a low carbohydrate diet, sure, I want to stay lean and it becomes reasonably effortless on a low carb diet, but I am afraid of Alzheimer's disease, having had a grandparent go through it for years. It was just terrifying to see. And it's my hope that I'm helping push that away by following a low carb diet and maintaining a high degree of insulin sensitivity.
Yeah, do you find, I mean, because people with the ApoE4 variant saturated fat is a concern. What is that context dependent, or what is your thoughts on that?
Shawn, I wish I knew more about it. I can't speak to it. I know Ivor Cummins, you got to have him on here, I guess, if you haven't, because I think he knows a lot about it. Partly because I think he said he is an ApoE4 individual, but I don't know enough about it.
Lark was questioning. She said you had mentioned some oxalates, and usually we hear about them in the context of kidney stones, because that's the most common type of kidney stone.
Uh-huh.
Do you find any other issues with that, and then other sort of phytochemicals that could be problematic?
Yeah, so I don't know anything. I mean, if we're talking about kidney stones, I don't know of any other plant source. I mean, Shawn, do you know, does the body have any way of getting oxalates except for from plants?
We can make a small, we endogenously make a small amount, but it's relatively small amount.
Okay, yeah. And then with regards to phytochemicals, I'm not sure how boldly I could speak to that. There is evidence to suggest these molecules can help. But how much they help, how much the person would have to consume them to get them to help, I don't know. I would guess my kind of uninformed opinion, because I don't know too much about them, would be to say these are substances that appear that they could be healthy, but does the person need them? No, we don't need them. But in the context of a typical American diet, if someone were focusing on getting more phytonutrients, could that help? Probably. That, you know, in other words, if we've pushed their health down so low, could getting more phytochemicals help? Maybe, but it also could be a confounding variable that they're just eating more fruits and vegetables. And on the conventional American diet, that's going to be a great step in the right direction.
Yeah, so I think there's somebody who wants to clarify a little bit more about fasting and burning fat and muscle instead. So she's putting in the context, so if you have fat to burn and you also have insulin resistance, then will you waste muscle with fasting, or will you preferentially lose fat first? What's the thought?
Yeah, so there's a situation, that's a great question. There's a situation called sarcopenic obesity, which is just the worst of both worlds here, where they have too much fat mass and they're losing muscle mass. And that is very much, I shouldn't say exclusively, but it's very much a function of the insulin resistance, where the muscle has become resistant to insulin's anti-catabolic and indeed anabolic effects. Yes, so if someone had fat to spare, that theoretically should mean they're not starving, they're fasting. However, in an insulin-resistant state, it may start to blur the line, and we would perhaps start to cut muscle sooner than we would want to, because insulin can't hold that. Insulin isn't working well enough to prevent the loss of the muscle. And so, yeah, I mean, that it's a provocative situation, and I am speculating, but I could imagine, I could speculate that being insulin resistant would drive muscle cutting, which is how I distinguish between fasting and starvation. However, that I would say is not common, and it could be reflective of just a profound insulin resistance. Sort of a resilient insulin resistance, whereas most people that are insulin resistant, once they start fasting, their insulin sensitivity typically improves very quickly. In fact, that's really part of the magic, maybe the only magic of gastric bypass procedures, is that you basically force starvation onto a person, and they get incredibly insulin sensitive very quickly. But I'm not at all advocating gastric bypass. In fact, I think it's terrible.
Yeah, I would echo that. I would just comment, I think that, you know, in the situation where you're exercise resistance training is going to steer you towards hanging on to more of that mass if you're in that weight loss situation. I think
Yeah, well said. Excellent point. I totally agree with that. I think everyone should do resistance training. I think one of the unfortunate trends in our society was this obsession with running. Don't get me wrong, running can be great. It really can. And Zach, if you ever hear this, don't take it personally. I think running can be great, but I think for the average person, they need to maintain muscle mass in order to maintain good health. And so everyone should be doing some resistance training. Just go to failure, just even a couple times a week, whatever you're doing, keep that muscle.
Yeah, I think well said. Specific tests for insulin, can you talk a little bit, because I think most people would agree that C-peptide is better than measuring an insulin, whether fasted or random.
Yes, yeah. So fasting insulin and fasting C-peptide both have drawbacks. They're relevant, at least. I would just even defend insulin, just because at least you've measured the insulin. Too often, it's overlooked completely, and there's pretty decent evidence to support that if a person's over 6 microunits per mil of insulin, that's going to dramatically increase their risk of developing type 2 diabetes. And so that level of 6, though, that is far more rigorous than conventional metrics in a clinic, where I've seen it where they say that normal insulin is up to 30, and that is just asinine. However, dynamic insulin is the best, albeit, of course, not easy at all to do. But the easiest way, as much as there is utility in invoking the Kraft insulin assays, and I bet a lot of your group here is probably so informed they know about it, but that's just when you give the person, I think it's a 75-gram glucose challenge, and you're measuring the insulin like every 30 minutes, essentially, for like 4 hours. And that's pretty rigorous, and no one's going to get that done in a clinic. An alternative to that is I think it's called a Hiyashi test. And essentially, after the glucose challenge, you could just measure 30-minute insulin increments up to 2 hours. And if the highest insulin, if the peak of the insulin curve happened at 30 minutes and it was down, it was lower at 60 and 90 and 120, that's good. That's a good pattern. If the peak happened anywhere else, that's not good. And it's likely reflective of insulin resistance. Now, Shawn, at the risk of having not explained that sufficiently and now shifting topics a little bit, I just feel compelled to mention that often I hear people invoking insulin resistance or a physiological insulin resistance that accompanies a low-carb diet or a carnivore diet. And I disagree with that completely. What we ought to say is that if someone has been strictly avoiding dietary carbohydrate, they will have an acute period of a glucose intolerance. So, Shawn, if you and I, or let's not compare us because that's not fair to me, but if we had two Shawns and one Shawn is eating carnivore and the other one's eating a standard kind of higher carb diet, if we took those two Shawns and dosed him with a 75 glucose oral challenge, carnivore Shawn is not going to clear that glucose quite as well and as higher carb consuming Shawn, because this higher carb consuming Shawn is in sugar burning mode. He's using that glucose well. In fact, I would say the problem is he's not using fat very well. Other Shawn is using fat, so it just takes the body a couple days to kind of go back to burning higher carbohydrate. That acute glucose intolerance is not the same as insulin resistance in any way, shape, or form. The pathological insulin resistance, like you get, in the average American on their way to type 2 diabetes, and physiological insulin resistance, which is when the body becomes insulin resistant for a healthy purpose, what they both have in common is that insulin isn't working quite as well, and this is important, insulin is higher. So it's hyperinsulinemia and insulin resistance. That is insulin resistance, whether it's pathological or physiological. In contrast to the person who's acutely glucose intolerant because of a low-carb diet, their insulin levels are low. That is not insulin resistance. They just acutely don't metabolize glucose as well when they've loaded the system with it. And then the instances, just to back up briefly, physiological insulin resistance happens with the two P's, and that is puberty and pregnancy. These two periods of explosive human growth. The body becomes insulin resistant to, in part, facilitate selective growth, whether it's the explosive vertical growth in the teen or whether it is explosive, fat growth and placental and fetal growth on mommy to help baby grow as quickly as possible. And that's partly why mom becomes progressively insulin resistant throughout the pregnancy. She's at her most insulin resistant when baby has the biggest need to start laying down all those chubby layers of fat. Anyway, huge tangent. I beg your pardon for it, but let's not confuse acute glucose intolerance in a low-carb individual with insulin resistance. Even if we want to put a little gild on it and call it physiological insulin resistance, no, that is not accurate. Let's be accurate. It is a glucose intolerance. It is acute. And if the person knows they have to do a glucose tolerance test, well, then eat higher carbs for a day or two before or something like that.
Yeah, I've seen, I kind of liken it to alcohol, because if you're not used to having alcohol, when you take alcohol, you're going to be affected by it very quickly. Whereas someone who's an alcoholic has those, cytochrome P450 and other alcohol dehydrogenase enzymes upregulated. But so just because you kind of
that's a good comparison. I like it. If you're alcohol or if you're glucose naive, you're not going to tolerate it very well.
Yeah. One of the things, and it's kind of interesting to say that the average American, I think the fasting insulin is like 8 typically, so
yep.
That's relatively high. Well, one of the concerns I've heard is because glucose is metabolized in the liver relatively quickly, whereas C-peptide hangs around a little longer, and some people will say that is a more reliable test for insulin production because C-peptide, as you know, is cleaved from the the proinsulin.
Yeah, it has a different half-life. Yeah, so Catherine Crofts out of I think she's in New Zealand. She published a paper that suggested that C-peptide had, I believe her paper was, it had no more value than fasting insulin. But I don't want to invoke her study incorrectly. I'm pretty sure that was what she found, but I can't I can't remember it conclusively. And then it was her contention that the dynamic tests, the Hayashi method and the Kraft assay, were the ones to more definitively do that, to determine insulin resistance. And I agree with that completely. My only counter to that is that academically it is nice to know, but in practice, it's just impossible. No one's going to go in to their clinician and have them do that. It's never going to happen.
Yeah, the clinician probably scratch your head and has not heard of it anyways.
Yeah. I mean, it's hard enough getting them to do one insulin assay rather than have you sit there at the phlebotomy clinic for 2 to 4 hours. That's not going to happen.
All right, let me see if there's one other question here. Somebody said if there's one test, and that's always a horrible question, but if there's one test to detect metabolic health, could you off the top of your head test?
Yeah, well, of course, I always have an answer.
Okay.
Unfortunately, one of my great flaws, but frankly, I'd say to test metabolic health, Shawn, let's just define that as metabolic flexibility. And if someone had a little gas tracker device or respiration tracker device, and these are getting smaller and sexier all the time, where the person can exercise with them, but it's just this little measurement of gas exchange. And a lot of even gyms or wellness centers have these little devices nowadays, but you can measure what's called the respiratory exchange ratio, which is an indicator of which fuel they're predominantly burning. Are they fat burners or sugar burners? And if after the person eats a mixed macronutrient meal, they should be in sugar burning. Everyone is easily. In fact, maybe the easier test is they come in fasted, and is there evidence that they are in fat burning mode? That is metabolic flexibility. When they fast, they go to fat burning. A type 2 diabetic or even pre-diabetic insulin resistant person has lost that transition. They are unable to treat human metabolism as a hybrid. They're stuck in sugar burning mode. So you start to fast the person, they don't experience that shift in respiratory exchange ratio that reflects a predominant burning now of fat. They stay in sugar burning mode. So I would say at the easiest, measuring the RER through just a breathing analysis would be maybe the simplest way of determining metabolic health. But that's just one way to define it.
Perfect. Ben, thank you so much. We've used up an hour of your time, and I think we could go for 6 hours, as you know.
Yeah.
I think everyone here, I'll speak for everyone. I'm sure everyone was enjoyed that, and keep up doing the wonderful work. Thank you again so much, and thanks for joining our little humble abode here at MeatRx.
That's great. Shawn, you're doing great. You're doing great things. I'm happy to have been a part of it today. Thanks for the invitation.
Thank you, Ben. And I look forward to your work and continuing your success in what you do. Thank you.
Yeah, in fact, go buy the book, everyone. Help a poor professor out. Why We Get Sick. Available for pre-order right now.
Oh yeah, I didn't know that, Ben. Actually, Why We Get Sick. So it's located on Amazon, I suppose.
Yep. Anywhere books are sold, but right now pre-order.
When did it? Oh, it's pre-order, so it's not been released yet.
Yeah, July. Yeah, so it's just all about insulin resistance. Actually, it's
okay.
What is insulin resistance? So I define it, how we get it, why it matters. So I go through all the evidence that indicates how insulin resistance is relevant to a shocking number of diseases, and then what to do about it.
Wonderful. Well, when it gets closer to release, let's get you back on so we can push. I really think you're doing great things, Ben.
All right. Thanks, Shawn. Thanks again for the invite. See you, buddy.